নেক্সট হচ্ছে 9 audiology and its evaluation. Audiology and its evaluation. So let's remind the entire auditory pathway once again. So first we have the pinna, right? We have the pinna. Then here comes my external auditory meatus and external auditory canal. Then here comes my tympanic membrane at 55-degree angle. Now I am inside the middle ear. So in the middle ear, what we have? We have at first the malleus. So this is the handle of malleus. Now incus. And at the end we have the stapes. Malleus, incus and stapes. Now with the stapes, what we have? We are now in the footplate of stapes. Ultimately it is the footplate and it vibrates ultimately the oval window. So we are now inside the organ of Corti. So how do we make it? Organ of Corti is just like this. Superior. With the superior I have the posterior and the behind, and here comes the lateral. Okay, now all of this opens in the organ of Corti. So that little bit of, here comes my organ of Corti, 2.5 to 2.7 tons. Okay. So this is my organ of Corti. Ultimately, from the organ of Corti, I have what? I have my entire auditory pathway. Entire auditory pathway. That means the nerves comes from here, and ultimately it goes toward my brain. That is the auditory cortex. Ultimately it goes the auditory cortex. So let's write the pathway. At first we have pinna, then external auditory canal, tympanic membrane, then ossicular chain, then organ of Corti, then auditory pathway, ultimately auditory cortex. Now defect at this part, that is up to footplate of stapes. That means external ear, in and middle ear. This is called up to the middle ear. It is called conductive hearing loss. In the inner ear, it is sensory hearing loss. The inner ear, it is neural hair loss or retrocochlear hearing loss. It is also called retrocochlear hearing loss. Ultimately, both of these are sensory neural pathway. So this part, osculation, this is conductive hearing loss, and from organ of Corti to the rest of the part, it is sensory neural hearing loss. Now we will come to the different type of test for this. Very short. Now one part comes that what is the main function of the middle ear. This middle ear, what is the function of it? Okay, so just simply writing this in the middle ear section. This is my middle ear. So function of middle ear, one is impedance matching, means matching, that means transformer action, how does it do this? Who does that? We'll discuss how it does the thing. And second one is dampening of sound by stapedial reflex. Stapedial reflex is controlled by 8 and 7 nerves, 8 for afferent and 7 for efferent. Okay. So nerve number 8 and 7. 8 is stapedial. Okay. Now comes the transformer action. How it does that? There's two things. One is aerial or hydraulic ratio, that is the tympanic membrane, the surface of tympanic membrane. Effective surface area is 55 millimeter square, but the foot plate of stapes that ultimately vibrates the oval window, it is only 3.2 millimeter square. So the aerial ratio comes 17. So here comes the aerial ratio, area, that is 17. And then comes the lever ratio. Lever ratio means that the handle of malleus is 1.3 times larger than the handle of incus. That means when it vibrates, incus vibrates 1.3 times more than the malleus. So it is the lever ratio, and obviously the lever ratio is 1.3. So it is 17 aerial ratio, it is 1.3. On combining both of this, we have the transformer ratio, that is 22. 22 is the ultimate transformer ratio, that we need to remember. So I'm cutting this simple. We don't need to remember all this. 22 transformer ratio. Also it does another thing, that is phase difference between the compression of oval window and rarefaction of the round window prevents noise cancellation and hearing loss. Okay, we know it already. Let's work on this part. Tuning fork test. Now comes to the main part, to differentiate both of these. So here comes my pinna. The pinna, here the air vibrates the tympanic membrane, ultimately it vibrates the entire pathway. So air conduction makes the entire pathway vibrate, and most conductive important part of this conductive pathway is middle ear. Okay, so middle ear is the most important, obviously we have seen that. And bone conduction, what does bone conduction? Bone conduction only measures the sensory neural hearing loss, that means from the organ of body to the brain. So bone conduction only here, bone conduction only in this case, but ear conduction is for both of this. Entire pathway is ear conduction. Okay. So how does the it happens? Bone vibrates the mastoid, mastoid vibrates the cochlear fluids, and ultimately the entire auditory pathway. Ear conduction is better because amplified sound is heard by the organ of body. So ear conduction is ultimately better. Obviously, that's why we have evolutionary, we have air conduction law. Now comes the test, Rinne's test and Weber's test. So how to check the conductive hearing loss? For conductive hearing loss, CHL, we have one thing, that is Rinne will be negative, or okay. So let's do it very quickly. In Weber test, if the sound is lateralized to the same ear, that is the same side, that means that conductive hearing loss is there. Because why? The external noise is not heard in the defective ear, therefore bone conduction is better. Okay. So I just write it like this, like this. In Rinne's test, Rinne's test, Rinne positive means AC, that means air conduction is more. Okay, in that case there are two scenarios in positive, that is normal ear or sensory neural hearing loss. If in case of Rinne negative, means obviously the opposite, bone conduction is more. I'm not writing that right. Okay, in that case, in the sensory conductive hearing loss or severe SNH. Okay, what happens here? It is the false negative Rinne test. Why? Because in severe sensory neural hearing loss, the stimulation occurs through the opposite cochlea. Stimulation by opposite cochlea. Okay. This is Rinne's test. And now in the Weber test, what we do? Weber test, if the sound is heard on the opposite side, that is OS, always opposite side, that means a simple one, sensory neural hearing loss. It is written in red here, so making it red. Opposite, so it is sensory neural hearing loss. If it is heard on the same side, yes, again it is heard on the same side, then it is also conductive hearing loss, because external noise is not heard in the defective ear, therefore bone conduction is better. Why? Then external noise not heard by defective. Okay, with the combination of these two, we can simply characterize most of the questions. Some points that Rinne is can differentiate hearing loss is more than 15 decibel. If more than 15 decibel hearing loss. Okay. That means air conduction and bone conduction must have a difference of 15 decibel. Okay. Severe sensory neural hearing loss. What when happens? Sudden severe SNHL when occurs. Obviously, it is sudden. That means one thing is infection. That is obviously viral infection. Edema, ischemia, or compression. Steroid is the treatment. Steroid is the treatment for this. Obviously, sudden case. That means patient will simply say, "Doctor, I after waking up in the morning, I cannot hear anything in my left ear or right ear." Okay, let's do it. Next question. In Weber, the tuning fork is placed where? The tuning fork is placed obviously in the, if I make the face like this, so obviously we can place the tuning fork in the forehead, in the vertex, or in the upper teeth. That means in the upper teeth. Okay. Teeth, that is upper obviously, and forehead. Next question comes that obviously the question says what causes conductive hearing loss. Okay, so the causes of conductive hearing loss I am writing here. For example, serous otitis media, otosclerosis. Next, sensory neural hearing loss. It is caused by, you already know it. One is Maynard's and acoustic neuroma. Okay, so we have to diagnose like this. So direct question won't be asked. This will be asked like this. Next test, if we write here comes, that is the acoustic bone conduction test and Scobac test. In Scobac test and acute bone conduction test, it is simple. In Scobac and acute bone conduction test, the examiner finds itself as a normal. That means the doctor is right. The examiner's hearing considered as normal. Okay. In acoustic ABC test, that means acoustic bone conduction test, simple. Tuning fork is placed on the mastoid part, while tragus pressed. So no air conduction is off. Okay. Tragus is placed so no air conduction. In that case, if ABC test, it is if the vibration is heard same as examiner, so it is normal. We have two findings. One is same as doctor or examiner, so it is normal. Shortened, so obviously it is doing bone conduction, that means bone conduction decreased, implies that SN. Now next comes the Schaubeck test. It is exactly same test, but here in Schaubeck test, Schaubeck, this is not done. So triggers, it checks both things. Air conduction is available, triggers is not covered. So here comes two scenarios. One is this. One is if the patient sound, the length of the vibration, it decrease or shortened. See, shortened, so same as like that, bone conduction is lost, so sensory neural hearing loss. But if it is lengthened, that means patient's bone conduction is more than the examiner's. What that means? It means that air conduction is lost. That's why he is hiring the external noise is dampening. That's why he is able to heard more than the examiners. The doctor is always right, so the patient has the fault. His air conduction is dampened, and ultimately it leads to say conductive hearing loss. These are the two tests. We have more tests like Gale's test for osteosclerosis and Shiger's speculum used for the external auditory canal. Negative Gale, no change in hearing loss with the pressure variation. Bing test, it is the same like for that CHL, and not so important. Osteosclerosis, obviously it is a CHL, osteosclerosis once again, and otitis media. So here we have Gale test, Gelle, Gale test, and for CHL we have another test, that is Bing test for CHL. These are just names and we can simply forget, not simple. Now comes the tuning fork part. The types of tuning fork we have. Our range of hearing is from 20 to 220 kHz. Okay, but the speech frequency is simply 500, 1000 and 2000 Hz. That means our note, one notes of 500, 1000, 2000, obviously it is band. Next, the most common tuning fork is 512 Hz. These are the basic informations. Now comes to questions. Let's do simple questions so you can understand it. These are just narrow book questions, and we'll do different set of question practice in the upcoming videos. For now, let's just focus in what we have right here. Okay. In a patient in decreased hearing, Rini's test in the right ear is negative. So we first write everything. This is the right ear. Rini is negative. So Rini negative. This means we have two possibilities. In this case, we have sensory conductive hearing loss or severe SSS. In the left ear it is positive. Okay, we have another ear as well. In the left we have Rini. Positive means we have again two options. One can be SNH and the other can be unnormal hearing. So which is true? So let's visit. Forty decibel of conducting hear is loss. So here is no conducting hearing loss here. So it is wrong. Bilateral 40 decibel hearing loss, CHL. Here can happen, but here never happens. So it is wrong. Left SSHL, wrong. So obviously it is left normal and right SSHL. Okay, it is right. Next question comes. A 38 years old gentleman reports the decreased hearing in the right ear. So in the right ear, we can say has decreased hearing for the last 2 years. On testing on for Rini's test is negative. Then Rini is negative. Rini negative means we have two options: CHL or SSE. Positive for the left ear. Left ear. Rini positive means we have normal or SNH. With Weber test, the tone is perceived louder as the left ear. Weber test is lateralized to left ear. Yes. So right here, conductive hearing loss that can happen, but it is said that Weber's is going lateralizing to left ear. So in this case, if the conductive hearing losses happens here, then Weber should come to this here. So this is not an option. This option is obviously colored, so it is the answer that Weber is going to other side, so it will happen this part. Rini negative and Weber is opposite here, so second option, severe sensory neural hearing loss. The left ear can have both. One is normal or SNHL. So conductive hearing loss is not an option, but sensory neural hearing loss should be an option if the Weber's is lateralized to the right ear. So this is not an option as well. Next question: if the Rini test positive, that means it's written obviously more precisely in both ears, then what we should do? So Rini positive, so is right and left. Rini positive means what? Rini positive means that we have either normal ear or SNH. So in both cases we have either normal hearing or an SNHL. So we need more tests to confirm which is. With a single test we cannot confirm, we need at least two tests. So no intervention as both eyes are normal. We cannot say this, right? Obviously a patient comes to me, that means he having some kind of problem. So remove wax from the right ear, not an option. Since any neural hearing loss is not in here. Repeat Rini's test. By repeating we cannot precise anything. Do Schobach test. Schobach test means we can measure CHL as well as SNHL. If it is lengthened, then it is CHL. If it is shortened, then it is SNHL. If here Schobach test is shortened in any case, then that is SNHL case. Okay. Next. we can see that in the right middle ear pathology or external ear pathology, that means conductive hearing loss. Okay, Weber test obviously same here. So in the right, if it is said inner ear pathology, then it is SNH footnote. So we can write like this, that if Rini is negative in the right ear, I'm writing in Bengali, right ear Rini negative, means we have two options, SCHL or SNHL. Severe sensorineural hearing loss. And Weber is going to the opposite ear, that means in the left ear. Okay, so the answer is severe sensory loss. Okay, this is just a demo. And if it is said external ear pathology, external ear pathology or middle ear pathology, then it is obviously referring to CHL. If it is said inner ear pathology, it is SNHL. Done.